And we're delighted to welcome our friends from Mexico and Dr. Ruiz. So please give him a warm welcome from us all. Thank you. Thank you.
Dr. Burt, do not leave the room. First of all, I would like to thank to the AIMS charity for putting together this fine meeting. Thank you very much. And I also want to apologize for not being yesterday at the professor's dinner party. We were traveling from Holland to the United Kingdom because we were lecturing on for a group of persons with multiple sclerosis in Amsterdam. Well, I would like to go with the program that we have organized in Mexico. This is a very simplified way to describe the first HSCT done by Professor Donald Thomas in 1956. Later on in 1960, the first HSCT was done in Mexico, and then things have gone very nicely. And in 2021, we did the 1,000 HSCT for multiple sclerosis, and very recently, along this year, we did a 1,500 HSCT transplant for persons with multiple sclerosis in Mexico. This is the patient number 1,500 that we did in Puebla some time ago. We are currently the largest patient volume autoimmune disease HSCT private treatment center in the world. Both Professor Gomez-Almaguer and myself have conducted more than 3,000 HSCT procedures for different types of diseases for more than 20 years. And we try to provide personalized, comprehensive care that helps patients manage their symptoms. Very recently, we were granted this accreditation program, the Certificate of Completion, by these two institutions, the FACT in the United States and JC here in Europe. And this is interesting because this certifies cellular therapy centers all over the world. It is interesting to mention that in America, in Latin America, only 3 centers have been granted this distinction. Professor Hammerschlag in Brazil, Dr. Gomez-Almaguer, who runs our facility in Monterrey, and in Puebla, we have been granted this certification. This picture here depicts Ana Sureda, who is the current president of the European Bone Marrow Transplantation Society that runs the JC accreditation program, as well as Professor Daniel Curiel, who is an authority of the fact the day that we were given this distinction. We also, since the start of our program, have been reporting regularly our data to the Center for International Blood and Marrow Transplant Research. We are part of Be the Match, and we have ISO 9000 certification. The leaders of our team are Professor Gomez-Almaguer in Monterrey, who runs our facility in that particular city in the north of Mexico, and myself. There are some data of our CVs depicted in that picture, and both of us have the fortune of having 2 sons who are also hematologists. Andres Gomez de Leon, who is the son of Dr. Gomez-Almaguer, and Guillermo Ruiz, who is my son. They run our program when we are some other place, such as in this occasion, for example. This is the numbers that we have done since we started our program in 1993. We have been transplanting patients for 30 years. We have done up to now 2,010 transplants, and 1,752 are auto transplants. This is our experience along 30 years. And as you can see, in the case of allogeneic transplants, we deal mainly with patients with acute leukemia. And in the case of autologous transplants, we graft mainly patients with multiple sclerosis, but we have done multiple myeloma, acute leukemias, lymphomas, and so on. One of the salient features of our program is that we do the transplants without a hospital. We do the transplants on an outpatient basis. And we have been able to show that the number of complications, if you do the transplant outside the hospital, are substantially reduced. These are the places all over the world of the persons that we have grafted in Puebla, in our facilities. And in addition to grafting patients, we have been very interested of showing our experience to the worldwide community of scientists. So we have presented our data in the International Society of Hematology meeting held recently in Glasgow, and then we also attend the bone marrow transplantation tandem meetings, the American Society of Hematology, the European Hematology Association, and the Transplantational Cellular Therapy, which is the new name of the American Society of Bone Marrow Transplantation. So we are present in these academic activities, and we have been showing them our results and publishing all our experience in different types of journals all over the world. We are now presenting our data in neurology meetings that, as it was already said, neurologists do not very clearly believe in this transplant as being useful for persons with multiple sclerosis. And we have now interest in presenting our data in the neurology community. Last year, we presented our data in the meeting of the American Society of Hematology, and for that particular experience, we presented data on 1,300 multiple sclerosis patients, in which we were able to record the patient-related outcomes of the transplants. Professor Bort has been kind enough to visit us in Puebla for this forum held in 2019. And very recently, I organized the bone marrow transplantation meeting in Puebla, and Professor Bort also was there to show us his experience. So we believe, and we have published data about the usefulness of getting HSCT as soon as possible in the course of the disease. We recently published this information in which we have shown that long-term results of autografting persons with multiple sclerosis are better in those not exposed to prior disease-modifying therapies. This graphic here refers to the changes in the EDSS score in persons given or not disease-modifying therapies before the transplant. And it is clear that the drop in the EDSS score is more marked, more pronounced in those persons who have not received disease-modifying therapies. Another salient feature of our program is that we split the doses of cyclophosphamide in 2 blocks apart, and we have been shown, we have shown that this way of delivering the cyclophosphamide, the full doses, diminish the side effects and have the same efficacy. So our method is very gentle with the kidneys and with the heart. The cardiac toxicity and the renal toxicity of our method is substantially diminished by using the 4 doses of cyclophosphamide in 2 blocks apart. So both the kidney and the heart are spared by using these. And the usefulness of the transplant, that has been clearly stated, stems from the amount of cyclophosphamide that you deliver. Most programs all over the world employ 200 milligrams per kilo, and we do the same, but as I said, we split the doses in 2 blocks apart. You can see our method here. 2 initial doses of cyclophosphamide, 50 milligrams per kilo in each dose, and then a period in which we deliver the filgrastim prior to the 3rd and 4th doses of cyclophosphamide, And at the end of the transplant, we employ rituximab. We have shown, as I said, that this way of delivering the cyclophosphamide is safer for the patient. We have registered our trial in this site in the National Institutes of Health so that everybody can see what we are doing and everybody can see the exact doses of the drugs that we employ, and they can reproduce our method anyway. We have shown data about the feasibility of the full outpatient conduction of our method. We have also shown that this is safer than keeping the patient in the hospital, and we have published our results in primary progressive, secondary progressive, and relapsing remitting multiple sclerosis. Response, as we define it, is either stabilization or improvement in the EDSS score. And as you can see, the best results are obtained in relapsing remitting, 85% response rate, which goes up to 88% at 18 months. But as you can see in the picture, we have also got significant responses in both primary progressive and secondary progressive. All this information is published in the papers that we have done. When we did the transplant number 1,000 in persons with multiple sclerosis, we published this paper in Frontiers in Neurology. And when we did our 1,300th transplant, we presented orally our experience in the annual meeting of the American Society of Hematology, in which we described the patient-reported outcome, PROs, which are now an interesting way of having the results of treatments for different diseases. As I said, we recently did the 1,500 HSCT transplant, and we have also shown that since we keep the cells of the patient up to 48 hours, we do not need to freeze the cells. We do not employ cryopreservation of the cells, not for patients with myeloma and lymphoma, and now not for patients with multiple sclerosis. This reduces substantially the costs and also is related to a better cell viability when doing the transplant. So it is safe to employ the chemotherapy, employing refrigerated, non-frozen grafts in persons with multiple sclerosis. We do not need freezing devices for our method. Stem cells are harvested and reinfused within 48 hours, and as I said, this improves viability, reduces manipulation, and reduces contamination. Our method has been shown to be safe. Out of 1,600 patients that we have done up to now, we have had only 3 fatalities, and in the last, and we have no had fatalities related to HSCT 5 years of the transplant. As Professor Bird already pointed, all the transplant programs are related to fatality, sometimes not even depending on the procedure itself, but to some other things. But as I said, our fatality rate is very, very low, 3 cases only. Outpatient conduction of the transplant reduce infections during neutropenia, and the type of bugs that you get during neutropenia are substantially less aggressive than the bugs that you get if you stay in the hospital. This has been shown. Less than 5% of patients develop neutropenic fever, and this compares with the number of febrile neutropenias, which is about 16% if you do the transplant in a hospital. Most patients require only one apheresis procedure to obtain enough stem cells. Very few of them require 2 and up to 3 apheresis procedures. This is very infrequent. 90% of patients we can graft with only a single apheresis procedure. We have shown that in our hands, 1 million cells per kilo is enough to complete the graft, but most of the times we get substantially larger number of cells. And we have now also published that most complications can be addressed as outpatients. We do not need a hospital to resolve the febrile neutropenia. Our hospitalization rate is 4.2%, and the causes of hospitalizations include neutropenic fever, pneumothorax, dehydration, and nausea. We have also shown that in most patients we can complete the transplant without transfusing them, either red blood cells or platelets. 89% of the patients did not require a red blood cell nor a platelet transfusion. And so we can complete the transplant without any transfusion. We have also shown, as I already displayed, that progressive forms of multiple sclerosis respond to HSCT, such as this lady. This lady had a progressive form of multiple sclerosis, was transplanted in Puebla, and now she's running marathons all over the world. Many of you know her very well, Sahira. As I said, the response rates are better in relapsing remitting multiple sclerosis, but we do have some responses also in secondary progressive and primary progressive multiple sclerosis. And this information has been published related to the self-reported changes in the EDSS score in persons with multiple sclerosis after autologous transplant. This is our single-center experience. These waterfall plots indicate that after the transplant, the EDSS score goes down or remains stable in 85% of persons with relapsing remitting multiple sclerosis. In this subset of persons, only 15% of patients do not have a positive response, which is either stabilization or improvement in the EDSS score. In the case of primary progressive, the figures are 80% versus 20%. And in the case of secondary progressive, 79% versus 21%. So, as I said, better results in relapse and remitting, but also results in all types of the diseases. Not only the EDSS improves, the quality of life also gets better after HSCT. We have found statistical differences between baseline quality of life, including mental and physical quality of life. These plots here refer to the physical and mental quality of life at 3 months and at 12 months after the HSCT. You can see that there's improvement, and in this radar plot, the blue zone is the data before the transplant, and the pink plot is the data after the transplant. So quality of life as judged by several variables as are those depicted in the plot improve substantially. Life after HSCT is easier than you may think. You do not need to stay in a bubble, but measures such as avoiding crowded places and clean diet have shown to be effective in preventing infections after HSCT. Regular lab tests performed by a general practitioner and revaccination are advised after the transplant, as has been already presented and discussed. We have shown that the prevalence of COVID-19 after HSCT is not increased, and we have also shown that the course of COVID-19 infection during the procedure is not as complicated as somebody could feel. As a result of the changes that we have done in the methods to conduct stem cell transplantation, both Professor Gomez Almaguer and myself were granted by the Center for International Bone Marrow and Transplant Research this Distinguished Service Award, as I said, mainly as a result of the changes that we have done that enable us to graft a larger number of persons all over the world. This book here is the textbook of hematology in most universities in Mexico and also in some other countries that speak Spanish. We are now in the sixth edition of the book, and it's interesting to mention that also as a result of the changes that we have done in the way to transplant persons, this distinction of Distinguished Alumni Award was granted some years ago. Also, in the university where I trained in San Luis Potosí in Mexico, I was granted this honoris causa doctorate, mainly because of the changes that we have done in the way of conducting hematopoietic stem cell transplantation. I will finish my address showing you this film. This is the core, the Center for Outpatient Residents. Patients are received there. This building is devoted only for persons having a transplant in Puebla. We have 26 suites. Each suite has a living room, and there are 2 rooms, one for the patient and one for the accompanying person. The bathrooms are equipped with all the needs for persons with restrictions in mobility. And there are also common areas for the persons having HSCT in Puebla. This is our campus in Puebla. We have also a roof garden. Some of the persons here who have been there can say that this is a nice place to have the sun, which is one of the attractions of our country. We get sun more frequent than in here, that's for sure. And people enjoy being up there because the temperature is nice and the sun is bright most of the times. There's also a dining room within the building that is devoted only for persons that have transplants, and this applies not only for multiple sclerosis, but also for patients with hematological conditions such as the ones that need a stem cell transplantation. We have been able also to show that even haploidentical transplants can be conducted fully on an outpatient basis without ever using the hospital. These are the places in which we see the patients during their stay in the core, in the Center for Outpatient Residence. We have 5 consulting rooms, and patients are seen every 48 hours by one of the physicians in the group, and the nurses are continuously in the core taking care of the patients and recording their vital signs very frequently. We also have a cafeteria in which patients can have their meals. They can either have their meals in the cafeteria or they can ask for room service. By not using the cafeteria, we were able to go ahead with our transplant program even during the COVID-19 pandemic, and we were able to transplant the patients without having too much contact among them, and then we had to close the cafeteria. But now we have reopened it since the COVID-19 problem is practically over. So in addition to the core, which is the place where we keep the patients for a 28-day period, we also have some very close to the core building. We have a special vans to transport the patients from the core to the clinical RIS. This is building B of the clinical RIS, where we have the consulting rooms, and In the first floor, we have areas to deliver the chemotherapy. As I said, this is the chemotherapy room within Clinical Risk. We do not use the hospital to deliver the chemotherapy. And we also have a separate area to conduct the apheresis procedures. This area is specifically designed for apheresis. We have nowadays 6 apheresis machines, and we conduct these procedures, as I said, outside the hospital. As a result of special requirements in our country, the cells have to be injected to the patients in the hospital, and this is the only moment in which they go to the hospital. This is my office within the Clinical Risk. So this is the last part of the presentation, and I would like again to thank the AIMS charity for putting together this meeting and for granting us the opportunity to present our experience. And I also would like to acknowledge the patience that you all have had for this presentation. Thank you very much. I will be happy to take some questions if we have enough time.
This isn't really a question as such. I just want to say a personal thank you to you, Dr. Ruiz and Dr. Juan Carlos. I went out to Mexico, to Puebla, to the Ecuador 5 months ago and had a stem cell transplant. I was in a wheelchair when I went there. My EDSS was at 6.5 and it's now between 4.5 and 5, and that's down to you. So thank you.
Congratulations.
This might be quite a random question, but so yourself and Dr. Federico use rituximab after compared to the UK, which uses RATG. I was just kind of wondering why you both chose to use that instead of the RATG.
Why we employ rituximab instead of ATG? Well, there are some salient points. One of them is rituximab is substantially less toxic than ATG. Rituximab is substantially less costly than ATG. And what we have found now by the combination of cyclophosphamide and rituximab is that the results are about the same. I feel that the main part of the transplant is done by the cyclophosphamide, and most centers would employ total dose of 200 milligrams per kilo, which is the one that we employ. And with that, plus the rituximab, is that we try to obtain the abrogation of the immune system of the persons.
Hi, thank you so much for the presentation from everybody. They've been wonderful. I just had a question for you. I think like most people here, I am living in the UK, and therefore if I was to go somewhere like your clinic and have treatment, I'd then have to come back here and liaise with the NHS here in England. And that's something I've heard pros and cons from people about what that experience has been like. In your experience, what have your patients reported? Has it been easy getting here and getting the hematological work done? Have they had problems, or are you able to help them on this end if they come back home and their doctors don't know what tests need doing? Is there stuff that you give us to take back to our doctors to say this is what we need to follow up?
Yes, the patients remain in our facilities for 28 days, and after that they come back to their countries. It would be great to have them for at least 2 or more years to see what happens to them, but this is absolutely impossible. So we rely on the willingness of the patients to provide us with information about how they are doing. This is a major problem, we know that, but that's the only way that we can know what is happening with our program. The response rate of the patients that we have grafted along these years is about 30%. That means that 70% of patients would not let us know how they are doing, because they do not have time or very many reasons. So we rely on patient-reported outcomes. And the other thing is that most patients coming from abroad to have the transplant come despite the recommendation of their neurologists. So that makes the problem even worse. Fortunately, there are very many tools to analyze the EDSS score by the patient itself, and we rely on that. And we also have the aid of general practitioners that will be willing to help the patients when they come back. So most of the times, either general practitioners or specialists can help the patients to provide us with data after that. We are also open to make recommendations about possible changes in the treatment. And along that line, we have been able to graft a group of persons by a second chance. I mean, we have persons that have received by now 2 transplants after failing to the initial one. But yes, things are changing, and in the last years, we have seen that neurologists are starting to believe in this procedure as being a therapeutic tool in this condition. Thank you.